All right, we are going to talk about back pain for a second. So one of the things that I see clinically a lot is patients come in, they've got chronic low back pain, and they've had this imaging that shows this finding, and that is the diagnosis they were given. So patient might have midline low back pain that gets worse with extension, better with flexion, but they've got this MRI report that shows that they've got a bulging disc at L4, L5, or maybe L5, S1. There might be some mild, what's called central stenosis, which is narrowing of the spinal canal, or they might have some mild or even moderate transforaminal or foraminal stenosis, which is where the nerve roots are actually exiting the spinal column. And they walk around saying that the reason that they have back pain is because they have a bulging disc. And in some people that might be the case, because we can have discs that are painful, and that happens quite often. But the majority of the time, what I see in clinical practice, the patients that come to me, is a lot of the times what they have on imaging doesn't match up with what we find clinically. And so when we have those situations, the number one thing that I need to do, and that every good doctor should do, is a good thorough physical exam and history that is trying to evaluate what structures might be causing them pain. The big things for me that I want to know with patients on the history side of the equation is, are there any past injuries, traumas, car accidents, things like that? Those are always important. Past injections, surgeries, things that they've had in the past, what structures were treated if they had injections, whether they worked or they didn't work. And then activities of daily living that are problematic for them, or if they're active in the gym, activities in the gym that are problematic for them. That can tell me a lot about what structures are causing them pain. And then last, which is always an interesting one, is what is the worst position to sleep in and what is the best position to sleep in. If somebody comes to me and they've got low back pain and they tell me, "Doc, I cannot lay on my stomach to sleep. I used to be a stomach sleeper until this back pain, and it is just the worst pain imaginable," to me, I'm already flagging, oh, this might be a facet-related issue. If they come to me and say that, when they're in the gym, they can't do deadlifts or squats because they get some low back pain, to me, I'm now thinking, okay, maybe this is some discogenic pain. We might also have some mild damage to the supraspinous or the inner spinous ligaments that are basically connecting the spinous processes at each level. Or we have some neurogenic inflammation of the cluneal nerves or the medial cutaneous branch off the dorsal rami, because a lot of those nerve issues get worse with flexion. They can also get worse with extension, but generally we see that in the gym with deadlifts and squats and things like that. And so it's really, really important to, if you are seeking out treatment for what you've been diagnosed with on your image finding, to maybe reframe that and try to find a physician who is going to do a good, thorough physical exam on you, and then use the imaging to basically corroborate or to see if they match up. I can't even count how many times I have patients come to me and they've got this finding on their imaging, and I do physical exam and it shows something very, very different, and I treat the very, very different thing, and they are 80 to 95%, if not better, pain relief. Their image finding didn't get better. I didn't treat whatever they had on that image finding, but they are still better. Now, caveat, sometimes patients come in and they have foraminal stenosis and they have pain that radiates down the leg, and my physical exam confirms that their pain and potential weakness on that side is due to impingement of that nerve root as it's leaving the foramen. And so we end up treating what was found on imaging. But the most important thing is using the physical exam to evaluate, is the imaging showing us what structural changes have occurred that are causing pain, or are those just structural changes that are there? Remember, if you take, maybe not remember, I don't know if you knew this, if you take a healthy population of older patients above, I believe this study was above the age of 50, and you stick that, and they don't have back pain. All these people do not have back pain. If you stick them in an MRI, 50% of those patients are going to have findings on their MRI, including bulges, herniation, facet arthropathy, and degenerative disc disease. 50% of them, and none of them have pain. So just remember that the imaging does not show you what is causing your pain. It shows you what structures might be causing your pain, and then the history and the physical exam need to support that. All right, everybody. See you later.